Right ventricle, the next chamber in sequence with the right atrium. It receives the deoxygenated blood from the right atrium inside the right ventricle, and from there, when it pumps, the blood goes into the pulmonary trunk via the pulmonary wall. Welcome all, myself Dr. Ankit Khandelwal, MBBS and MS in Anatomy. This is my YouTube channel, Anatomy Explained. I also run few Facebook pages, groups, Telegram groups, and email ID that has all been given in the link in the description box below. So the topic for the today is our right ventricle. Let's start the anatomy of the right ventricle. So as already discussed, the right ventricle is in sequence, that is, it comes after the right atrium. So as we have seen the anterior view of the heart, so if we see again the anterior view of the heart, then it appears like this. We have this right border mainly formed by the right atrium. Then we have this inferior border mainly by the right ventricle, also by the left ventricle at its left border, at its left corner. And from here we have this left border mainly by the left ventricle. Over here, if we make the grooves, then this would be our right coronary groove, this would be our anterior interventricular groove, and this chamber over here in between, that is our right ventricle from the anterior aspect. So other chambers here are, this is the right atrium, and as we already know, that is the left ventricle. This is the apex of the heart formed entirely by the left ventricle. So if we look at the right ventricle from anterior aspect, the few points in the right ventricle that we already know, we can quickly revise. That right ventricle forms the majority part of the sternocostal surface of the heart. Sternocostal surface of the heart. So the anterior part of the heart, anterior surface of the heart, which is just behind the sternum and the costal cartilage, entirely, or not entirely, but yeah, mostly by the right ventricle. It also forms the 1/3 part of the diaphragmatic surface. 1/3 part of the diaphragmatic surface. The other 2/3 part is formed by mainly by the left ventricle. So this is our right ventricle and the few contributions by the right ventricle to the surfaces, and already we know the borders, mainly it contributes in the formation of the inferior border. So now how to study the right ventricle? To study the right ventricle, we have to cut it open. Now if you cut it open from its anterior wall, if you cut it open from like this, then obviously it looks like a triangular in shape. So it looks like triangular in shape. Now if we make few walls, then already we have seen inside the right atrium. If you have not yet seen, then you can go in the previous video. We have done about the inside and outside of the right atrium, and before that we talked about the whole chambers of the heart. So if you go back and you have already seen it, then you may be knowing that between the RA and RB you have this placement of the tricuspid valve. So this is our tricuspid valve over here, which is around 2.5 centimeter in its diameter. In an adult, mature tricuspid valve is around 2.5 centimeter. So it is lying more or less oblique, slightly tilted according to its sagittal plane. So this would be the location of the tricuspid valve. And we know that in the tricuspid valve there are various cusps. They are tricuspid, so there are 3 cusps. So there is the anterior, posterior, and the septal cusp. So there are actually few cusps over here which are going inside towards the inside of the right ventricle. These cusps, you may be knowing that they are connected via few cords which are known as chordae tendineae, and these chordae tendineae, on the other hand, they are connected inside the wall of the right ventricle via the papillary muscles. So these constitute our papillary muscles. These are our chordae tendineae. These are our chordae tendineae, and these are the various cusps of the valve. So this whole thing, that is the incoming channel. What is this? This is the incoming channel by which the blood from the RA is actually going inside the RV. So this is the direction by which the blood goes from RA to RV. So this incoming channel is obviously roughened, and this incoming roughened area in the right ventricle is known as trabeculae carni. Is known as trabeculae carni. So this is the incoming part. The outgoing part, if you remember, the outgoing part, the upper side, we had this pulmonary trunk which actually divides into a right and left pulmonary artery. From the left pulmonary artery you have a connection, that is your ligamentous arteriosus in adults and ductus arteriosum in embryos. So here we have the ligamentum arteriosum. So this is your pulmonary trunk, which is the outflow part. This is the pulmonary trunk, which is the outflow part of the right ventricle. So obviously this outflow part has to be smooth. Why? Because when the ventricles contract and they send the blood to the pulmonary trunk, if that outflow is not smooth, then there could be turbulence in the blood which is inside the pulmonary trunk, and that is what is not needed, because that has to go nearby to the lungs only. So this outflow part is known as, this area is smooth, this area is smooth, the outflow part, and that is known as infundibulum. So this is infundibulum, that is the outflow part. This is the smooth part. Infundibulum literally means what? What is the meaning of infundibulum? You should know it is funnel shape. You also remember in anatomy, we talk about infundibulum when we talk about the parts of the fallopian tube. The lateralmost part is known as the infundibulum because that is again funnel shaped. That is to catch the secondary oocyte which is coming from the ovary during ovulation. So same, the funnel shape is known as infundibulum inside the right ventricle. So this is our incoming part, that is the trabecular carni, and that is the outgoing part. The blood will go from here. Remember, we are making with the red color just to avoid confusion, but the red color over here does not mean it is oxygenated blood, it is a deoxygenated blood. So incoming and outflowing part. Now a little bit of embryology also over here. So incoming part, that is a trabecular carni. We can write in another page also. That is incoming part, that is our trabecular carni, which is actually roughened due to various muscles, and the outgoing part, which is your infundibulum, they are embryologically formed from different structures. And what are those? Incoming, or the muscular part or the roughened part of the ventricle, right ventricle, is formed by the proximal 1/3 of the bulbous cordis. That is also a very frequently asked question in any exam. This infundibulum, or the outflow part of not just the right ventricle, even the left ventricle, or both the ventricles, it is formed by the middle third. It is formed by the middle 1/3 of again the same bulbous cordis, or the same bulbous cordis. And between these two, that is the incoming and outgoing channels, we have a small crest over here, because the tissues are, the shape is actually quite drastically different. One is smooth, one is rough. So that crest between them is known as our supraventricular crest. Supraventricular crest, which is also known as your infundibuloventricular crest. So where is it located? It must be located somewhere between over here, between the incoming and the outgoing part. Now what we see over here, if I make few dots over here with this color, what should be present over here? What should be present? It is a septum between the RV and the LV. So obviously that is our interventricular septum. This is our interventricular septum. Again, a little bit of its embryology. Interventricular septum, basically the lower part is a muscular part, which is a thick part, and the upper part of the interventricular septum is the membranous part, which is a thin part, which is mainly formed by the endocardial cushions as well as the conotruncal swellings. So that is the upper thinner part is the membranous part, and lower part is the thicker or the muscular part. This basically is interventricular septum. And as we know that the thickness of the RV is 1/3 of the thickness of the LV. So if we take a coronal section, or if we take a transverse section, not a coronal, but if we take a transverse section, then the right ventricle in the TS, right ventricle, would be crescentric in shape, and this LV would be a circle in shape, because if this is say LV, that is say RV, then the interventricular septum over here is pushed towards the RV because of the thickness of the wall of the LV. So therefore in the TS, the RV will look more of crescentic in shape, and in TS, the LV will be looking more of a circular in shape. This difference we have to know. The thickness of LV is 3 times that of RV, because a simple thing that the RV has to pump blood only to the nearby organ, that is the lungs. So the pulmonary vascular resistance is very less compared to the systemic vascular resistance. So pulmonary vascular resistance could be around 15, 20, or max 25 to 30 millimeter mercury. But the systemic vascular resistance, against which the LV pumps blood, it is around 120, 130, 140, could be more than that, normally around 120 to 130 millimeter of mercury in the systolic pressure. So obviously as the resistance is more, obviously the LV has to work more, so its muscles are more hypertrophied, therefore it is around 3 times. Okay, so these were the incoming and outgoing channels from the RV. Incoming channels, the trabecular carni, and the outgoing is the infundibulum, or the smooth part. Now what are these? Now these are basically, if we talk about tricuspid valve over here, which is also known as AV valve. The right side AV is atrioventricular valve over here. So it has 3 cusps, and those 3 cusps are actually pulled down inside the ventricle by these papillary muscles, and the connection between the papillary muscles and the cusps is due to this chordae tendineae. So let us see how they function. How do they function? They function as if, supposedly, we have this as the cusp over here, we have this as the cusp over here. Okay, now these cusps are actually pulled, or actually they are attached to the margins via the few of the papillary muscles over here inside the right ventricle. So where are these papillary muscles? These papillary muscles are inside the right ventricle. So if we try to make a more of the cusp over here, more of the cusp over here, okay, so there will be more of the chordae tendineae, there will be more of the chordae tendineae, okay, and obviously there will be more of the papillary muscles, there is more of the papillary muscles. So we won't go into the details of it, but we have to understand few basic things, that if suppose these are the cusps, these are the chordae tendineae, and these are the papillary muscles, these are the papillary muscles. Now what is happening is, each papillary muscle, each means each, there are three groups: anterior, posterior, and the septal group. Anterior group, posterior group, and the septal group of the papillary muscles. So each of these papillary muscles is attached to more than one cusp by the chordae tendineae. So it is not that there are three group of papillary muscles, there are three cusps, so one papillary muscle is allotted to only one. No, each papillary muscle or each group of papillary muscle is connected to at least two of the cusps via the chordae tendineae. So where the anterior papillary muscle is connected to anterior and the posterior cusps of the tricuspid valve, the posterior papillary muscle, which is a bigger one, is connected to the posterior and the septal cusp of the tricuspid valve, and what is remaining is being connected by the septal papillary muscles. Septal, there are many papillary muscles, so the septal one will be connecting into the anterior and the septal group, connecting mainly into the anterior and septal group. But these two are clearly defined, that is the anterior group of papillary muscle and the posterior group of papillary muscle connected to these group of cusp by the chordae tendineae. Till now fine. Now what happens is what happens is there is also a structure which is known as septomarginal trabeculae, which is known as septomarginal trabeculae excuse me, also known as the moderator band, also known as the moderator band. Now what it is, let us see in the previous image. So see, I told you that this was our interventricular septum, the thicker part and the thinner part. Forget about thicker, thinner, just remember that this was our interventricular septum over here. This whole was our interventricular septum. Now what happens is that from above, that is from inside the right atrium, as we saw that inside the RA there was SA node, and close to the coronary sinus opening there was the AV node over there, okay, in the triangle of Cox. So from that you have the AV bundle which runs, atrioventricular bundle which runs, and it divides onto this junction of membranous and muscular part of IV septum into a right bundle and the left bundle branch. These are your two bundle branches. From this right bundle branch, there occurs a few of the muscles which are going towards the anterior papillary muscle. So these few muscles which are going towards the anterior papillary muscle. So suppose this is your anterior papillary muscle, okay, and these few groups which are carrying these right bundle branch or right branch of the AV bundle, these are known as your moderator band. These are known as your moderator band. Now what are they doing? Or the septomarginal trabeculae. Other name is septomarginal trabeculae. I repeat again. The AV bundle is coming from the AV node. AV bundle is going from atria to ventricles. Then at the IV septum, it separates into right and left bundle branches. The right bundle branch will be going towards the RV. The left bundle branch will be going towards the LV. This LVB and that is your RVB. So as this RBB is going towards the right side of IV septum, then it goes along with a specialized muscle cell known as the moderator band or the septomarginal trabeculae directly to the anterior papillary muscle, which will actually contract first and it will pull on the chordae tendineae. So I repeat again what is happening. What is happening is that if we take this one as the anterior papillary muscle, okay, just imagine this one is the anterior papillary muscle, and let us imagine that okay, this one was the moderator band, this one was the moderator band over here. So the impulse which was coming from the right bundle branch directly went into this anterior group of papillary muscle. Now this anterior group of papillary muscle is going to contract and it is going to pull the chordae tendineae. So what is the use, what is the implication or the action of this or the role of this structure is, which structure the moderator band is, that it sends the impulses, the moderator band sends the impulses earlier on onto the papillary muscle and the chordae tendineae. Therefore the chordae tendineae are already in a state of partial contraction even before the ventricles are into systole. So what is the role of all of this is that when the ventricles are in systole, then obviously the pressure of the blood is going to more inside the ventricle. They are going to push, the blood is going to push these cusps towards the right atrium. Now if this chordae tendineae and the papillary muscle are not working, then there would be tricuspid regurgitation. The blood will go from ventricle to atrium, again from atrium to ventricle, from RV to RA, RA to RV. That doesn't make any sense. Therefore, when the ventricles contract, then these cusps, they are prevented from regurgitating back into the RA by the contraction of papillary muscle, which will actually pull the chordae tendineae. So as this moderator band already stimulates the chordae tendineae few milliseconds before the RV contracts, so already our tricuspid valve is pre-protected by this earlier contraction of the chordae tendineae, so that the blood does not regurgitate back. And when the ventricle is in systole, the atrials are in diastole, and the blood is being filled inside the RA via the SVC and IVC. So that is the basic role of this moderator band. That is the basic role of the moderator band. Okay, so this moderator band is actually covering is actually transmitting the impulses from the IV septum into the anteripapillary muscle. Now these whole walls, that is all of these four walls, if you write over here, that is your tricuspid wall. Let me use this different color. That is your tricuspid wall over here. Okay, then you have the mitral wall, that is on the left AV wall. Then you have the pulmonary wall. Again, it is having three semilunar cusps. It was related to the RV. See, three semilunar cusps. And you have this aortic wall. All these walls are actually surrounded by a collagenous tissue that is known as the fibrous rings. So there are fibrous rings surrounding these walls, and all these fibrous rings, they form a structure which is known as a fibrous skeleton. Okay, all these walls surrounded by fibrous skeleton. And mind you, all of these walls are present, surface marking is present behind the sternum, that is in the central part of the heart. You have all of these walls. So therefore they form a fibrous skeleton around which all the other tissues start to develop. Okay, so this was a little bit of the fibrous skeleton, and that was a little bit of your right ventricle inside. So to summarize everything, there is an incoming channel, a rough one, there is an outgoing channel, the smooth one, and there is a little bit of anatomy of the tricuspid valve, the functions of the papillaries, the chordae tendineae, and also a little bit of your moderator band. Apart from this, a little bit of embryology is what is needed. A little bit knowledge we can also add on over here about the pulmonary trunk. Pulmonary trunk, where it is found, how it is found, how does it actually present inside the body. So if you look back again over here, the pulmonary trunk, if you remember, it is going like this. Then it divides into the two pulmonary arteries, which are actually behind the aorta and behind the SVC. Now about this pulmonary trunk over here, when does it start and when does it divide? So the starting point and the end point of the pulmonary trunk. So if we can just elaborate this, that the starting point of the pulmonary trunk is behind the sternal end of the left third costal cartilage. Okay, so it starts where surface marking is behind the sternal end of the left third costal cartilage, and where does it end means where does it divides into right and left pulmonary artery is again the sternal end of the left second costal cartilage, that is around the sternal angle, that is angle of Louis that we did in this thoracic cage part, sternal angle or the angle of Louis. So it is around 5 centimeters. This whole pulmonary trunk is around 5 centimeters in its length, and it divides into this part. Okay, there is a little bit of the pulmonary trunk also. So if you are still slightly scratching your head that what is this now sternal end, so for that you have to look on all the videos that we have done in thoracic wall and thoracic cage. But just a brief idea, this is a manubrium body and the xiphoid. This is your first strip, second, third, fourth, fifth, sixth, and seventh. So this pulmonary trunk actually starts behind the third and goes over here, that is a pulmonary trunk location, and then it divides at the level of sternal angle into the two pulmonary arteries behind all this sternocostal cartilage. That was a brief of the pulmonary artery or the pulmonary trunk. Okay, so I hope that is complete of a right ventricle. I hope you like the video. If you like, then press on the like button, try to share it. Any comments of any other things that you want to add on or some of the topics, most welcome. If you have not yet subscribed, it's high time you subscribe it if you want to learn about the whole human anatomy. Coming up the next lectures would be obviously on the other chambers of the heart, that is our LA and LV, left atrium and left ventricle. Till then, guys, bye bye, stay safe, see you soon.